Spinal immobilization versus spinal motion restriction. An overview of the REMS protocol. First and foremost, your patient assessment is key. When you are dispatched to a trauma incident, how will you decide if you're going to backboard your patient, apply a spinal motion restriction device, or simply transport them in the position of comfort? This decision depends on your assessment findings. There are some special considerations within the REMS protocol to be aware of. Patients under 14 years of age should be fully immobilized with a backboard and collar if they experience a traumatic event or injury. Patients who are intoxicated with drugs or alcohol should also be fully immobilized with a backboard or collar after a trauma. Patients who have an altered mental status, are unconscious, or have new onset neurological changes or deficits should be fully immobilized with a backboard and collar. Full spinal immobilization refers to the traditional backboarding procedure many EMS providers have been taught. This procedure and skill set has not changed. Please refer to the Spinal Immobilization Supine Patient Skills Checkoff Sheet for reference. Standing backboards are no longer an approved practice for ambulatory patients. Again, the full spinal immobilization procedure utilizing a cervical collar and backboard has not changed. Spinal motion restriction refers to placing a properly sized cervical collar on a patient who was involved in a traumatic event. Evaluate the mechanism of injury in addition to your patient assessment. If the patient is alert, oriented, and an adult not complaining of any neck or back pain, apply SMR. Dangerous mechanisms of injury that warrant spinal motion restriction on a patient denying neck pain include, but are not limited to, a fall of greater than 3 feet, a high-speed motor vehicle accident, a motor vehicle accident with ejection or rollover, a dive into shallow water, a pedestrian or bicycle struck accident, or an ATV or UTV accident. In addition to evaluating the mechanism of injury, there are special circumstances that may arise in which spinal motion restriction is recommended for the trauma patient who was otherwise not obviously injured. Patients with known spinal diseases should receive spinal motion restriction. If a language barrier is present between the provider and the patient, which could potentially compromise the full and thorough, detailed physical assessment, spinal motion restriction is advised. If the patient's GCS is less than 14 at baseline, spinal motion restriction is advised. A patient with distracting injuries, such as multiple fractures or other open wounds, should receive spinal motion restriction as a precaution for their traumatic injury. What if your patient has none of the above? If none of the above circumstances, considerations, mechanisms of injuries, or complaints included within the protocol exist, then your patient, despite their trauma, could be simply transported in their position of comfort. It is, of course, vitally important that you assess your findings, scene description, and interventions are all thoroughly documented on every patient care report. If your patient was involved in a trauma and you decide to transport them in their position of comfort as the most appropriate transport decision, then your documentation is even more important to help justify that decision. Do you have any additional questions? As always, please refer to the REMS protocol. This one is listed in the Trauma Emergency section and entitled Spinal Immobilization and Clearance. It was last updated November of 2015. Your training division here at Caroline Fire Rescue is also open for business and willing to answer any questions on this topic. Thank you for your time.